Hello, everyone. I'm Alice Sheridan. I'm an editor at nephSAP, and I'm here with Martina McGrath, also an editor. And we are speaking with Dr. Daniel Coyne and Dr. Morgan Schoer about largely the role of parathyroidectomy in the treatment of metabolic bone disease, of chronic kidney disease. As many of you know, Dr. Coyne is a professor of medicine in the Division of Nephrology at WashU in St. Louis. He received his medical training at Case Western Reserve, and his residency was at Emory University. He then did his nephrology fellowship at Washington University and has been on faculty at WashU for over 30 years. Dr. Coyne is the medical director of the primary academic dialysis unit and the director of the medicine multi-specialty outpatient clinic at Washington. Interests since 1998 include phosphorus control, secondary hyperparathyroidism, and the role of phosphate binders, vitamin D analogs, and calcimimetics. He has been involved in numerous trials of phosphate binders, vitamin D analogs, and calcimimetics. And he has co-authored or authored a large number of publications, including over 40 articles directly related to phosphate and PTH control in chronic kidney disease and end-stage kidney disease. He manages patients post-parathyroidectomy, has done so for over 30 years. Dr. Schoer, Morgan Schoer, is an assistant professor of medicine in the Division of Nephrology, also at WashU, which is where she completed her medical school, residency, and fellowship training. She is interested in medical education and clinically in home modalities of dialysis. And Morgan is the associate program director for the nephrology fellowship. And she has recently stepped into the role of the medical director of their home modalities program. Welcome to you both, and thank you very much for taking the time to speak with us. Particularly, Morgan, I can tell you this time of year is typically a disaster often for program directors and assistant program directors, and for our faculty. So thank you very much for taking the time. Just to start off here, I was fascinated by the editorial. Parathyroidectomy is often not on the forefront of practicing outpatient dialysis doctors. And in my case, it is because we often have difficulty identifying those patients that have truly failed medical therapy. Commonly, at least with my population, it's patients that perhaps are not taking the medications as reliably, perhaps are not as compliant. How do you select your patients who are most likely to benefit from surgical intervention?
There are two main groups I try to focus on. First is the transplant population. If they're a good transplant candidate, there's pretty clear evidence that doing a parathyroidectomy beforehand not only makes their bones significantly stronger prior to their exposure to steroids, which are going to make them weaker, but also virtually eliminates the possibility that they'll have hyperparathyroidism post-transplant and require either long-term cinacalcet or other calcimimetic, or wind up getting a parathyroidectomy then. And post-parathyroidectomy transplant patients don't garner all the bone benefits that they do having it done prior to the transplant. So that's a big population. The younger people with high PTHs, I want to get them done. The second population is the fails, and nobody agrees on this. Certainly the guidelines say use it in failing patients, but they don't describe what that is. I generally want PTH persistently above 1,000 for a year or more, despite aggressive medical attempts at intervention. If they're getting hypercalcemic on your therapy, that's another good reason to say, okay, they failed and we need to move on.
Are there any data in the non-transplant population? We've, recently kind of observed a realignment by KDIGO in order to more fully incorporate the evaluation of osteoporosis into CKD-MBD. Martina and I were surprised by this to some degree in trying to edit this most recent journal. It's now impossible to discuss CKD MBD without discussing osteoporosis. There's too much overlap. It is such a thorny topic. Are there any data looking at benefit of parathyroidectomy on either tolerance to treatment of osteo or on outcomes of in bone fragility or fracture in this population?
In the non-dialysis population, we have really very limited data. And I think what you see in the guidelines is kind of a pullback from don't monotonically focus on getting the PTH lower, because you may create osteoporosis if they don't already have it. I think in the non-dialysis population, where parathyroidectomy is clearly indicated is if you have someone with primary hyperparathyroidism. They're hypercalcemic because of the high PTH. And these patients should get parathyroidectomies. They do wonderfully well. And you may wind up stabilizing their renal function or even improving it substantially. In the dialysis population, our aging dialysis patients have more and more osteoporosis. And we don't have strong data. And this is why I would love to see really a randomized trial of taking patients who seem to be failing therapy, say PTH is persistently above 600 or 800, and saying we're going to aggressively manage them for the next several years with medicines versus proactively do a parathyroidectomy. We need to know this answer. And a bone fragility is important. The observational data suggests the parathyroidectomy is actually better for the patients, that there's some evidence in the cohort studies that they have better survival. I'm not willing to say that's real, but I'll tell you, year after year, I'd tell the fellows, look around this unit. Some of the healthiest people are people we did parathyroidectomies in 5 or 10 years ago. So take it for what it's worth.
Well, I was surprised to read in your editorial, and I pulled the papers, one of which has looked at this, that there was a improvement in mineral in density, in bone
Yes.
density. I just can't help but wonder whether that's going to improve fracture. The sine qua non of bone fragility in the important clinical outcomes is fracture. And I can't help but wonder whether that increase in bone density may translate in a few years to better bone quality.
Yeah, Morgan, I don't know if you want to weigh in on that.
I agree with you. I think that seems likely. Having trained in Dr. Coyne's clinic, that was the way that I interpreted the data. I don't know that I have a paper that I could point to that shows that there is definitely a reduced fracture risk down the road, but without a doubt, the 5 to 10 improvement in bone density that has been observed in these patients post-parathyroidectomy would ideally translate to reduced fracture risk down the road. And these patients tend to have improved quality of life, improved bony pain and joint pain with this. And so I wonder how that could be related into these changes within their parathyroid axis.
Yeah, and I would only add, for about a decade as we have done parathyroidectomies, we did get bone mineral density before and about a year after. And everyone got better. And most improvements were almost uniformly 5 to 10%, which is gigantic improvements in bone mineral density. The only person I ever saw who didn't have it was a very young, healthy Black man who had a very high mineral density to begin with, and we were doing it for transplant reasons. So I think that data is very strong, that you do dramatically improve bone mineral density. Does that reduce fractures? We don't have the data. Does that make them live longer? We don't have the data. that's why a trial would be wonderful.
Absolutely. Are any forthcoming?
Not that I know of. Ironically, these are the types of trials that, in a perfect world, our commercial dialysis chains would run, because they get at the heart of how can we improve survival and quality of life in our dialysis patients. But there's no pharma market for this type of trial, and consequently, pharma isn't going to be interested in funding it.
Martina, I don't know if the Brigham or MGH have what's the standard for PTX prior to transport here? Is it uniform nationwide, or does UNOS have any criteria that we're now following?
I think it's extremely center dependent, like many things in transplantation, unfortunately. And I think, the threshold that you mentioned around about 1,000 is one that we often talk about pre-transplant. But, Dan, I'm fascinated by your comments on the post-transplant patients. I primarily take care of transplant recipients at the Brigham, and I think this is a really thorny problem. We worry about the allograft. I think what we sometimes see, though, is that the PTH is not that high. We don't tend to see these very dramatic levels. So then I almost feel like I'm talking to my endocrine surgery colleagues, and we're talking about parameters that are similar to primary hyperparathyroidism rather than secondary. And can you maybe give us some insights about how you think about what kinds of patients really need parathyroidectomy post-transplant?
If they develop hypercalcemia, most of these patients are treated with cinacalcet as a daily therapy. Amgen has done a very nice trial looking at that population, and it was placebo-controlled. It clearly, for most intents, resolves the hypercalcemia. It doesn't lower the PTH all that much. It's only about 10 or 20%. And there's no improvement in bone mineral density. And this was a 200-patient study with half of being on placebo. So you're not making the bones better. Now, you're dealing with the immediate problem, which is the high calcium, but they're now committed to that long term because the glands undergo very little, if no, involution. So they're not going to get smaller. You'll always have that extra PTH coming out. So in those individuals, if you're satisfied with long-term cinacalcet therapy, then that's where you are. But if you have issues with their bone strength, and some of these patients did develop adynamic bone disease. A small study did 10 biopsies in people treated for 1 to 2 years with cinacalcet. And shockingly, 4 of them had like no bone turnover. That's very concerning. So you don't know if you're using cinacalcet long term that if you're causing adynamic bone. So if you see increased fractures, I would get them off of it. Just do a parathyroidectomy and manage them that way for the hypercalcemia. The other option is to start looking more systematically at your outcomes in your center. We never measure the PTH in our pre-transplant patients without stopping the cinacalcet, and if they're on L-calcitide, they ought to be off of it for probably 2 weeks at least, so you can get a better understanding of how high the PTH is, and that's a better marker off of those drugs of how big the gland is and how likely you are to wind up with hypercalcemia and chronic cinacalcet use post. I apologize for the long answer, but there's a lot of points in there.
Great. And I think the other kind of piece that weighs into that a little bit is we sometimes use DEXAs with these patients. Can you tell me how you think about those?
Well, I almost want to say, why don't you tell us how you think about those? Because you're treating those transplant patients, and it's very frustrating to understand what to do with DEXA scans. If the bone mineral density is low, then I want to do things to make it better. Too often it's not particularly low, or it's in the mild osteopenic range, and they're old anyway, so you're kind of expecting that. And should this be a driver? And we just don't know. I do think that the optimal post-transplant patient does not need cinacalcet and does not have hypercalcemia. And if you're letting people through your gate to transplant, and you're seeing a lot of those, you need to reconsider what your cutoffs are for pre-transplant control of PTH.
So if I'm understanding, as a non-transplant nephrologist, you stop their edulcalcetide or whatever cinacalcet they're on and wait and see what their PTH does, and then consider a parathyroidectomy. Is that correct?
So if they're off of that therapy and their PTH goes up into, the 800 plus range, they've got probably very large glands. So high PTHs, that as the sections discuss, as soon as in CKD3 you start to get an impetus toward higher PTH, you're also getting growth of those glands, and they never involute. So when you're looking at these very high PTHs, unless it's some off thing where they were suddenly massively hypocalcemic that day, you've got really big glands in those patients. And so if you're seeing PTHs of 800 to 1,000 off of those, they've got big glands. And odds are post-transplant, they're going to secrete more PTH than their body needs, and they're going to wind up getting hypercalcemic.
And I'll add that at our center, I don't believe it's our practice in the transplant world to stop their calcimimetic and remeasure routinely, but we do use a lower cutoff for PTH for any patients who are on a calcimimetic. So rather than a pre-transplant PTH cutoff of 1,000 for patients who are only on active vitamin D, if they're on both a calcimimetic and active vitamin D, we use a PTH cutoff of 500.
So you have somebody going for transplant who's in an outpatient dialysis unit and has a PTH of 500 despite edulcalcetide, rocaltrol, whatever. You would actually send them for a parathyroidectomy. I think that's far more aggressive than I'm currently doing. It's good to learn these things.
It's interesting to look back at the prevalence of parathyroidectomy post-transplant prior to the introduction of cinacalcet.
Mm.
And it was almost non-existent. The rate was about 1% a year. And it wasn't uncommon that these were patients who were actually just many years post-transplant, and they started to get hyperparathyroidism again. And so now they were sent, rather than this very, we didn't see huge amounts of hypercalcemia post-transplant prior to the cinacalcet era. And you can ask old transplant docs about that, I guess.
That is a fascinating point.
Uh-huh.
So I would say, and I don't want to come off as, I am the great contrarian, but I think we've missed an opportunity to improve the overall health of transplant patients by having great medical therapies to control the PTH, but not the size of the glands.
And consequently, not the bone health or quality of life improvements that tend to go along with the parathyroidectomies as well.
Absolutely.
So getting back to the non-transplant patient, do any of these caveats hold? Are we just masking a pathophysiology with the calcimimetics, do you think? I mean, we follow markers that are profoundly imperfect.
Yeah, if they're adherent to dialysis and receiving these medications, a secondary marker you can look at is alkaline phosphatase.
Mm-hmm.
And if you've got I've frequently compared total alkaline phosphatase to bone-specific alk phos. I've never seen a substantially elevated bone-specific alk phos in anyone with a total alk phos of 100 or less.
Mm.
And it's not that hard with persistent therapy to get the total alk phos less than 100, putting aside liver disease and other issues causing things. So if you can achieve that, you probably have relatively good control of their bone turnover. Is that the best management for them? Well, we've talked about that before. I'm not convinced that surgery wouldn't win out if we did a competition.
That's interesting. I suspect perhaps we are overusing slightly the calcimimetics or targeting too high a level. I was surprised getting back to the KDIGO. I don't know if you had seen the controversies conference that was recently published didn't really change any recommendations for therapy. I think it perhaps drew attention to the deficit in randomized trials and the deficit in definitive data that we have. Hopefully we'll get more head-to-head comparisons with the calcimimetics versus parathyroidectomy in transplant candidates, but also non-transplant candidates. I'm keenly awaiting those trials. Morgan, you're nodding your head.
I totally agree with you. Those trials and that data would be wonderful to have, but I am not presently aware of trials ongoing on that particular topic.
Any other questions, Martina?
You mentioned a little bit about the quality of life improvements that are seen post-parathyroidectomy. And I think given the major issues we have, particularly in dialysis patients with quality of life, that's probably something that's, maybe underappreciated in the field. Could you tell us a little bit more about that?
In qualitative studies using the parathyroid assessment of symptoms scale, patients have been found to have improvements in pain, fatigue, weakness, itching, irritability, feeling blue. A lot of these symptoms that patients on dialysis are already experiencing, and of course, pre-parathyroidectomy would be impossible to tease out. But these studies have shown significant improvements in these quality of life measures, and certainly anything that in patients who are appropriate surgical candidates, if we can help their quality of life, is certainly something that I'd be looking forward to.
I would only add what we've seen in our experience, and this first came to light when I was a young nephrologist, and one of the early patients I did came to me afterward, and he said, I fought with you for 3 years about getting the parathyroidectomy, and I finally had it. And I realized 2 days after the surgery, I woke up and I wasn't hurting anywhere. And I've never felt this good. And I always just blamed it on being older. And then he went around and convinced a bunch of other patients to get parathyroidectomies. So then I started paying attention to it and really asking patients. And many of them are not even aware of this kind of total body achiness they have until it's resolved post-parathyroidectomy. And the improvement is very quick. Some people report it within 2 days. Others say over a few weeks. Some say it totally resolves their pain. Others say that they feel just much better. And isn't that what we're trying to do? So it's very gratifying. And then it gets back to the question, well, if I'm controlling their bone turnover with medications, but I can make them feel so much better and control their bone turnover with a parathyroidectomy, maybe it would be better to do a parathyroidectomy.
It seems like trying to quantify the symptom relief.
As Morgan mentioned, in the primary transplant literature, they have a validated tool to give people. And that's been applied in the dialysis population in other studies by other groups, and have seen the same thing. About 50% of patients who undergo parathyroidectomy report a marked improvement in quality of life on this scale intended to tease out symptoms from hyperparathyroidism.
I mean, I don't know if we have many other interventions in dialysis that produce that level of improvement in quality of life.
Absolutely.
Yeah.
It was shocking to me when I first became aware of it, and it's always gratifying talking to a patient a few days after the surgery in the hospital or after they're back in the unit, and them telling me how much better they feel.
Mm.
And yet, again, and I defer the transplant to Martina's expertise. It's so many of our patients are much older, and it is an invasive therapy. And commonly, you try to avoid the OR. It's patients avoid it, but also their clinicians, perhaps wrongly so. Perhaps I reach to medical therapies more readily in my 80 plus age group. Symptom assessment is difficult. And if we had hard outcomes, I mean, this is why I'm so keen on looking at the fracture rate. I think there was a trial, the PROCEED trial looked at BMD, bone density. Perhaps if we wait the 3 or 4 years to assess the fracture rate, we would have some confirmation with hard outcomes. Not to minimize at all symptom improvement. It's just sometimes it's hard when they have symptoms from many different sources. And I'm waiting on harder outcomes, perhaps.
Sure. Well, and the complications of post-surgery. So there is an increased hospitalization post-parathyroidectomy. It's almost exclusively driven by hypercalcemia and hypocalcemia, which is not enough treatment for hypocalcemia and too much treatment for hyper, and then overreacting. So it's not uncommon somebody comes in hypercalcemic, they stop all the calcium, and then they're hypocalcemic and they get readmitted. And so that was part of the impetus for writing this is, it's a bad idea to stop all the calcium, even if they're hypercalcemic. Just decrease the dose, and this too will get better. And hypocalcemia is quite common because nephrologists are shocked sometimes at how much calcium it takes to control people immediately in the post-parathyroidectomy period. It's not as we put in there 2 to 6 grams, 6 grams of elemental calcium a day. That's a huge number of pills to be taking, and it sounds like you're trying to kill the patient, but in fact, you're going to get the calcium to be 7.5 to 9 is a good range. If they're above 9, I start cutting the dose. If they're below 7.5, I'm going to be increasing it or certainly checking it in 2 days. You've got to throw a lot of calcium at this. And the joy of it is it all goes into their bones. That's what's making the bone mineral density better. And that's what's resolving the hungry bone syndrome.
I think another point that we ended up making in this paper that I found compelling and sort of ties in very well with your opening statement about a lot of these patients who end up with uncontrolled hyperparathyroidism may have gotten there somewhat through potentially non-adherence. And what does that mean in terms of managing them post-parathyroidectomy? And so there seems to be a bit of a trade-off here. Post-parathyroidectomy, perhaps reduce pill burden, eventually improve phosphate control, decrease need for phosphate binders and dietary adherence. But upfront, a lot of education on the importance of absolutely adhering to this potentially very high aggressive calcium regimen post-surgically.
Absolutely. Much of the symptom burden is from the GI intolerance of the calcimimetics. That's absolutely correct. Well, it's an interesting and extremely controversial topic. We appreciate your input here in educating us and our audience.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.